It's my wife's name.
Hello, everybody. Good morning, good afternoon, good night, wherever you are around the world. Thank you, Ashu, for pretend that we were talking before about his name, and then now I'm very glad to be here today with my great friend Alex Amir Aalam. Thank you so much for your presence here with us in this webinar, my friend. Thank you so much.
Thank you so much. It's a true privilege and honor for me to be in this pod dinner. I want to thank you. I want to thank Ashur. I thank Keonor for the invitation, and of course all the board members who just elected me to be here with you and share some information and just increase knowledge for ourselves and for others. So thank you for the opportunity to do that.
Thank you so much. It will be a very good opportunity for all of us. I will introduce you, and then we can talk about something before your presentation, or you can go directly for your presentation.
Sure.
Let me introduce you, Dr. Alam. Dr. Alam graduated with a DDS degree from the University of Nice, France, and he specializes in advanced periodontics at University of Southern California, Los Angeles, right? And
Yes, correct.
Dr. Alam is a diplomate of American Board of Periodontology and a diplomate of the American Board of Oral Implantology. He is a clinical research in implant dentistry and clinical associate professor at the USC School of Dentistry in the Department of Advanced Periodontics. And he maintains a private practice here in LA. That's amazing. Thank you so much to be here. I'd like to thank you again to be here today with us, my friend.
Thank you so much. It's my
So,
pleasure. Thank you.
you you will you will show us the FAST technique, right? The
Yes.
FAST technique. What it does mean?
So it's a fibrin-assisted soft tissue promotion. This is basically a technique that we worked on from early 2012 with Joseph Choucroun, and we started basically presenting that in 2014, believe it or not, and the first presentation was done at UCLA. This is basically a concept where we want to upregulate the periodontal ligaments that we have around the roots by stimulating them and hopefully getting more keratinized and attached tissue around roots, because as you know, a lot of the attention on PRF has been put on implantology and bone and related to side development procedures. But now we have, I think, a unique opportunity to have this hypothesis that we can, with autogenous growth factors, self-promote wound healing and create hopefully a healthy, stable, new attachment around the roots and try to safety it and not pull them.
For sure, for sure. That's
Yes.
very interesting, amazing. Thank you so much. So I think that I'm here, and then I'm waiting. I'm free. Waiting for this presentation. I think that will be amazing. Thank you so much. The floor is yours, my friend.
Thank you so much. So what I did here is that I'm going to give you a synopsis of this presentation that we created and discussing this. Am I full screen or not? Sure. I want to make sure I'm full screen.
Yeah, you're in full screen.
Oh, am I full screen?
Yeah. You can share.
Because I still see myself.
Yeah.
The presentation is not in full screen yet. Please go to your presentation.
No, you can
Okay,
share your presentation. Yeah, we can start your presentation.
Okay, good. Excellent. Got it. Thank you. Excellent. Good. You have me here?
Yeah,
Perfect.
you are full screen now.
Excellent. Perfect. So fibrin-assisted soft tissue promotion. I'm going to give you hopefully within the next 30 to 40 minutes a quick synopsis of the thinking process that was behind this treatment concept, this treatment philosophy that we use in mucogingival surgery today. And this is a concept that we've incorporated into our practice, been teaching in universities, of course, and across the world. So this is, I think, one of the new paradigms that we have today in mucogingival surgery that is growing. As we know, PRF is a technology that is becoming more and more popular among peers. And I think some of the newer applications cannot be denied today. And with the right indications and with the right techniques, we can get good results. So just to go back to what my friend Carlos mentioned earlier, as a periodontist, as oral surgeons, as reconstructive surgeons, we have the goal to rebuild soft and hard tissues that are deficient into the surgical site. And that can be from a hard tissue aspect or from soft tissue aspect. And we know today, of course, that the gold standard that we have in the regenerative dentistry is the autogenous tissues that are coming from the patient itself. Even though we know that we have amazing clinical outcomes, but as you can see on the slides, there are some shortage and limitations associated with the autogenous harvesting technique. And the main shortcoming that comes into my mind every time that we provide this technique of surgery is the morbidity associated with the surgical site. Every time that we have to do a harvesting from the chin, from the ramus, or from the palate of the patient, in instance, if you want to do a soft tissue augmentations, there is a second surgical site that is associated with more pain, more discomfort, and that has to be explained and accepted by the patient. The second limitations that we have here is the amount of tissue that we can take from one patient. Again, there is so much tissues that can be harvested from a palate of the patient or from a chin or ramus in the need of an autogenous augmentation. And for that reason, if we have to do a full mouth reconstruction, most of the time, a staging approach has to be incorporated. So for these limitations, the industry has shifted and forced us somehow to use a substitute allogenic grafting material or xenogenic material. And those, even though seems to be very attractive, have limitations as well. And the first limitation that come into my mind is the cost of this material. You have to understand that every time that you open a pouch of alloderm, or every time that you open a box of allograft material, you're adding $200, $300, $400, $500 worth of material to the procedure, and this cost usually is transferred to the patient's pocket. Another question, I will not enter this debate today, is the quality of the tissue that we're getting. Okay, every time that you're using a dermis product that has been sitting on the shelf with an expiration date of 6 years, I will always wonder myself, what is the true biological attribute of this tissue that we're using for our patients' reconstruction? Are we truly getting a true regeneration? Are we truly getting a true new attachment around those roots or around those implants that we're hoping for them to stay the longest time in our patient's mouth? And of course, for some people and from some religions, there is always the concern of disease transmission related to human-derived products or animal-derived products, and the norms of sterilization and handling that comes in the manufacturing of this substitute. So these products are associated with limitations as well, okay, as you can see. But if you look at the ideal check sheet of what an ideal material should be, for us, our group of research is a product that is autogenous, meaning that comes from the patient, that has a low cost, meaning that we can treat multiple patients, a lot of patients every day in and out, without being worried about the financial aspect to be factored into the treatment of our patient. We want a product that is available in quantity, meaning that we don't have to bring the patients and have them have multiple procedures done over months, and for that reason reduce the morbidity of the procedure, and of course aim for the highest quality healing that is available, and aiming for the true generation or the best repair that can be done. So this concept dawned on us most probably, I would say, in 2013, when I witnessed my wife Alina Krivitsky, periodontist that I worked with, pregnant, and I witnessed the miracle of life, where I saw my wife within 9 months being able to create and develop a whole other human being in 9 months. And us periodontists, trying to regenerate some tissues, regenerate some bone, every time that we would grow some papilla or grow some tissue around the roots of our teeth, we would make slides and go all around the world and present our pictures and just pump our egos, while the human being is able to do that millions of times a day. Ladies are able to do that every day on a daily basis, in and out, creating human beings in 9 months with highly differentiated organs such as the brain, the kidney, and the liver. And this was the core, the center, the muse of this research core, is we have to have a way to be able to, within ourselves, build up ad integrum the lost attachment and heal and repair the attachment that has been taken away by the disease or by the trauma. So this is basically the core, the center of this research project that we started in 2012. And the answer for me was when I met Dr. Joseph Choucroun in 2012, where I contacted him to social media, and I brought that concept to him. I said, Dr. Choucroun, you are working in France with a lot of implantologists, and you're doing a lot of work on the sinuses, on the bone graft, in order to try to rebuild some of the bone that is missing to place dental implant. But have you ever considered trying to rebuild keratinized and attached tissue around the roots of the teeth? And the answer was no. And from that moment, we started a collaboration and started utilizing PRF, and that was actually the first generation of APRF Plus that came into the market in 2013, and the publication that we put out there with the utilization of this technique, with the concept and hypothesis of regeneration around attachment and teeth. So as we know here, again on the quick summary, the platelet concentrated families are not new in dentistry, and they started from 1998 with Dr. Marks and up to 2017 and 18. I think the newest generation is the albumin PRF that my friend Carlos has been published as well. So there's a lot of changes, a lot of modifications that came into the family of this blood-derived autogenous concentrated. But the core is always the same. The core is that we always have a fibrin clot that is packed with growth factor that are released in a controlled manner over a period of 2 weeks. That's the concept of a PRF, and hopefully within 6 months with the albumin PRF that my friend Carlos has been working on, that will induce neogenesis and help tissue formation and wound healing. So this is really the foundation of the concept of the wound healing process of this blood concentrated. And what attracted me in using the APRF Plus here is because it was one of the only blood derivative technology that was able to isolate transforming growth factor beta, which is the superfamily of the BMP2 and BMP7's release here, that will help us to hopefully upregulate the fibroblasts and hopefully the cementum and the bone and get attachment around the roots. So again, I'm not going to go into the detail of the studies that we've done from 2009 and our group of study with Dr. Choucroun, but we can see that the different groups of growth factor have a release form of between 0 to 2 weeks in a controlled manner. But again, the APRF Plus has a 100 picogram per day of release of BMP2 that happens into the site, that is very, very interesting in the nature of true regeneration and true attachment that we're aiming to get around the roots. So, and again, if you look carefully at all the different growth factors that we have in the blood, they do actually work in a synergistic effect in all the different aspects of wound healing process, from the moment of the injury, from the moment of the blood formation with the PDGF and transforming growth factor, inflammatory phases with the release of vascular endothelial growth factor, which is really the most important growth factor that is needed for the neoangiogenesis, which is the formation of blood supply. And of course, at the closure of the wound, and this is again a growth factor that is most of the time overlooked and underestimated, which is the epithelial growth factor that is needed to get a good coaptation and primary closure during your surgical procedure and avoid secondary healing and opening the flaps. So you can see that all these different growth factors have a specific role into the wound healing process of our surgeries. The LSCC concept that was added in 2017 has changed the foregame of the platelets, because now we have an injectable form of growth factors that we can use into our surgical procedure. And as the research done by Dr. Shukrun, he was able to identify that 1.5% of the human mesenchymal stem cells are traveling into the blood, and he was able to capture a trace of them into the IPRF, the injectable PRF liquid form, and he was able to find that 0.4 to 2% of those cells were present into the injectable form. So the injectable PRF is a liquid PRF that has virtually no physical properties because it's liquid, very similar to the PRP technology, but is much stronger, much more richer in the cellular contact and in the growth factor concept. So we have here now a little balance between the PRF membranes that do have a physical properties, but that have, of course, stem cells, growth factors, but in a much lower concentration compared to the IPRF, which is the liquid form of the PRF family that is supercharged with growth factor, with stem cells, and with cells, but has a much less favorable physical attributes. And I think one of the benefit of this technique is that we're able to use these two concentrated to the best of their attributes and get the best clinical outcome. And again, this is some papers that were published in 2017, and you can see here by the low spin concept, we're able to, by comparing to the other PRF families, able to isolate to a higher concentration mesenchymal stem cell that are so important into the differentiation of the cells that we have into surgical site, and again with the concept of aiming for true regeneration and true repair around the roots of our dental implants. The concept again relies on spinning less with less G-force and maintaining those big cells that are floating on the superficial layers and capturing them and being able to use them into our surgical site rather than having the gravity of the centrifuge diffusing them into the bottom of the tube and being taken away into the red clot and not being able to use them. So this is again a little video to show you here how it comes like. It's basically a, so let me go back here. I'm not able to, oh, we have a little freezing of the computer. Excellent. Great. So that's okay. The video for some reason is not playing. So we have here, as I mentioned to you, the APRF fibrin membranes on your left-hand side of the screen that are packed with the BMP2, BMP7 that are providing a wonderful scaffold. And you have on your right-hand side the injectable fibrins, which is the IPRF that is packed with hematopoietic and mesenchymal stem cells, and it's the fusion of these two families of PRF that led us to the concept of FASTP, or the carrier concept, which is using the APRF as a membrane, as a scaffold that will help to release those growth factors over 2 weeks and then inject into the surgical site the liquid form of PRF that is much richer on cells and on stem cells, and allow this release of these growth factors over this period of time. One of the other advantages of using the APRF, and again, these are some studies that were done just recently, is that you can see those membranes are very porous. So correctly, they will have most probably a lesser attractive physical attributes compared to your LPRF membranes that are much denser, much stronger, much bigger. But the cell penetration of the APRF is much more due to its scaffolding properties. And I think this is where the mixture between the injectable and the membrane comes into a winning formula here by mixing those two technology and be able to get the liquid form injected into the membranes and the slow release over the 2 weeks. So you can see here, this is a table that was given to us by Professor Lynch, that we are basically fulfilling properly the concept of physiological regeneration that rely on 4 corners of the wound healing pattern. We need, of course, a scaffold, we need signal, scent, and of course, vascular and mechanical environment that are favorable for this concept to happen and this wound healing to occur in order to provide this regeneration. And the scaffold is provided by, as I mentioned to you, the PRF membrane, which are the solid parts that will hold the space and release those hormones, those growth factors, over 2 weeks. We have the signals that are basically the growth factors stored into the PRF membranes, but as well into the IPRF, the injectable form that we're going to add to the mix. We have the cells that are going to be attracted by the chemotactic effect of these cytokines and chemokines that we have added to the surgical site, and then ignite the wounds healing process. And we have, of course, an environment that has to be, of course, modified surgically to provide a surgical environment that is favorable for the regeneration. And we'll talk about it, about how we modify the surgical technique in order to improve the concept of biointegrity, and of course the release of VEGF, which is the most important growth factor that we have in order to get neoangiogenesis. And this concept of FASTP has been introduced for the first time in 2014. So this is the first time that at UCLA and in the West Coast of the United States, we had a symposium where this concept have been introduced, and this was hosted by Dr. Peter Moy and Dr. Shukroon, and I had the privilege to be one of the co-hosts and one of the speakers during that symposium. So as you know, there are hundreds and hundreds of articles that have been published today in the world of PRF and their applications in medicine, traumatology, cosmetology. But again, this is not new. Okay, this is something that is growing. This is something that is becoming more and more space into the practice. And I'm sure that most of the surgeons, periodontists, or dentists that are practicing a surgical procedure, we know today that PRF has a clear indications into the way that we do surgery, and we all have seen benefits into the applications of it. And I had the privilege in 2017 to be part of a group of research that showed basically by a systematic review that PRF has a statistically significant relevance in the utilization in surgical procedures, and in particular in the hard and soft tissue augmentation techniques that we use in a routine basis in our dental offices. So going back to the hypothesis that we had in order to try to regrow some of the attachment apparatus that was missing around the roots, this is again a study that was done again almost 11 years ago by a group in Australia that showed that PRF had a clear upregulating factor in the periodontal ligament. And this is again something that was very interesting to me, because as you can see, it has the opportunity to regenerate this fibroblast that we need here to try to induce keratinization. And one of the important observation of that article is that, as you can see, that it had a downregulation of the epithelial cells. And this was a great observation because, again, this is one of the cornerstones of what is expected from regeneration, which is the downregulation of the epithelial cells to not get a long junctional epithelium in the surgical site. And the discussion of this article really spotted on and mentioning that this downregulation of the epithelial cell that was observed was due to the presence of the BMPs into the PRF that had a negative feedback effect on the epithelial cells. So again, in 2009, we could see a trend towards a positive impact in vitro, of course, of the utilization of this PRF in periodontology. And now if you go a step further and look intracellularly, what is the impact of this PRF into the PDL cells, you can see that basically it acts not only by increasing the communication between the cells, so the extra cellular communication, but as well it helps by the upregulation of the protein synthesis and the multiplication of the cells. So again, it's a win-win aspect of the utilization of PRF in vitro in periodontology. So having this beautiful concept, this is the first surgery that I did back then to try to confirm this proof of principle for myself and for the group of research with Joseph Shukroun. So this was a patient that suffered from an advanced localized periodontal disease, and we needed to do a regenerative procedure to try to save this tooth. And we basically decided to test this hypothesis and see how we're able, by using PRF, being able to upregulate the PDL cells and see how we can hopefully get some new attachment around this root that has been infected and the attachment has been removed. Not knowing more back then, what we did is that we took some PRF membranes, we chopped them and packed those PRF membranes, as you can see, into the defect using the PRF membranes as bone graft particles, granules. But again, remember, these were the first cases we've done back then. And then we covered these PRF membranes chopped that we packed into the defect with another PRF membranes that we hope that will act as a bare membrane. Close the flap with our fine suturing technique and let the patient heal here. And you can see that only 6 months into the healing, we're able to observe a repair, a regeneration. Hopefully, of course, it's very difficult for us with a histology to assess the type of healing that we have. But remember, this healing was done without any material, without any augmentation. And the hypothesis is that we upregulated the PDL cells to induce the formation of new attachment into that root that was exposed. Same concept here again. Next case that we did, localized defect on that canine. We were again able, following the same concept of adding PRF membranes into that defect, hoping to upregulate the PDL cells and hopefully get more cementum, bone, and dentin and ligament around the root that was exposed. Following the same principles of the organic tissue regeneration concept, we can see that 6 months into the healing, we are able to get a wonderful healing without, again, the utilization of any biomaterial, but with the hypothesis that we have upregulated our patient's wound healing process into the surgical site and induce a wonderful autogenous type of healing. So the confusion came here is that if we have such a wonderful treatment concept, treatment modality in the literature and in vitro especially, why in mucogingival surgery the literature isn't conclusive? Because going back again into the literature and reading every paper that was published before, the results were not conclusive. It was more or less a hit and miss, and we did not know why some of the articles were providing good results and some of the papers were presenting not so good of a result. So what we did here with my wife Alina Krivitsky and Dr. Shukroun is that we sat down and we read every single article that was published in mucogingival procedures related to PRF, and we tried to understand what were the shortcomings of this technique and what we could do in order to improve the usage of this technology that is so promising, as you can see, in vitro, but not conclusive in the usage in our patients. And we divided basically the clinical outcome into three shortcomings. First shortcoming that we diagnosed basically on reading the articles and analyzing them is the mechanism of action, and we'll go into the detail of this concept, which is very important, the concept of volume and bite integrity. So the concept of volume is very important because most of the articles that were published before 2012, where we started publishing about this FASTP concept, is that they were using 1 or 2 membranes and hoping to see a miracle. Again, remember, the PRF concept is an autogenous blood derivative, meaning that if you want to see clinical results, you need to increase the volume of these membranes because we're dealing with picograms of release of autogenous level of growth factors. Not only the release is slow, but there is a lot of variations that happen between patients, age and sex, and we still today do not have a formula for that. So as an empirical rule, you have to upcharge the site and place as many membranes as possible in the hope of getting the most relief of those growth factors into the surgical site and get the best clinical translation. Again, putting 1 or 2 membranes and hoping to see clinical changes was not enough, and this is what we saw in most of the papers that were published before 2012, is that the practitioners were laying down 1 or 2 frozen membranes, actually in some of the articles that were harvested the day before, into the surgical site, and hoping to see an outcome that would be equivalent to a connective tissue graft. The second shortcoming that we analyze into our patients, into the articles that we review, is the different way of wound healing process. And even though, as you can see in the slides, that the PRF membrane has a very, very attractive texture that looks like a connective tissue graft, you have to remember it is not a connective tissue graft and will not behave like a tissue graft. And this is, again, I think, one of the biggest misconceptions that happened at the early age of the utilization and the deception of the PRF gingival surgery, is that people were comparing connective tissue graft coming from the palate with this blood derivative, okay? And that's, again, something that has to be very clarified. Tissue coming from the palate work by genesis, meaning that the genotype of the wound healing depends on the donor site. Again, these are the studies done by Lang and Lowe from the 70s and the 80s, where they would take connective tissue graft or free gingival graft from the palate, basically transposing the genetic part of the keratinization from the palate into the recipient bed and getting, again, thicker, healthier tissue, meaning that every time that you do a tissue graft coming from the palate, the genotype and the phenotype is dictated by the tissue of origin, which is the donor site, with transposing this keratinization coming from the palate into the mandible, for instance. And the cells that you've taken from the palate will start proliferating and basically making keratinization for you. In the PRF concept, this is completely different, because, again, remember, PRF will have tendency to multiply and replicate whatever you feed them most. So there is no donor site. So for that instance, we're talking about promotion, because the recipient bed will dictate the amount of tissue and the quality of the tissue that you will get. If you're using the PRF into an area where you need bone growth, you will get bone growth. If you use it in an area where you need cartilage, you'll get more cartilage. If you use it in an area where you need more keratinized tissue, you'll get more keratinized tissue depending on the original endowment of the site, because what PRF will do is to multiply whatever the site has to offer. If the site doesn't have keratinized tissue, you will not get keratinized tissue. So don't expect induction to happen in these areas. It will just replicate, promote whatever your recipient bed has to offer. And this is, again, these two concepts that have been mixed and matched, unfortunately, and led to a quality of the clinical outcome expected. PRF is a biological modifier and has to be assimilated and understood as one, such as your emdogain or your PDGF, and it should not be considered and compared to your connective tissue graft harvested from the patients. So I hope this is very clear, because this is the core differentiation between those two techniques. And again, going back to the indications and to the applications, I want you to understand that there is no conflict between utilization of connective tissue or PRF. Those two techniques are different. These two techniques have clear difference indications, and a lot of times they can actually be combined together in order to get the best clinical outcome for our patients. So I want to make sure that it's clear that this is not one replacing the other one, but it's a synergistic addition of this blood derivative that we have into our techniques today that will help us to get the best outcome for our patients. And the last concept that was neglected, I think, coming mainly from the surgical aspect of the procedure, is the concept of biotensegrity. This is a concept that was introduced in 1999 by the Professor Ingberg, pneumologist in the University of Harvard, that basically explained to us how cells are being able to be modified and challenged by pressure mechanoreceptors that they have on top. So every time that you put a pressure on a cell, you will basically change by pressure or tension the signals that are sent into the extracellular matrix that will change the protein synthesis, and you will have what we call an anabolic or a catabolic effect, which means tissue formation or resorption. And this is something that we've been noticing in our surgical procedures. Every time that you have a flap that has a lot of tension and you close this flap, on top of your bone graft. Again, these are studies done by Carlos Tinti from Italy. He observed that we will have a lesser amount of bone formation into the surgical side versus a flap that was very passive, that will allow the neoangiogenesis and the formation of the bone happening without the pressure coming from the flap. And the same as well in the mucogingival surgery studies done by Pini Prato, where he noticed that every time that he would have a tension on the flap, the amount of primary root coverage will be always compromised compared to a flap that would be much more passive and much more relaxed. And in this discussion of this paper, he was not able to explain the reason why. It was just observation in the statistics that we made. But we know now from the studies done by the Professor Ingberg, the biological explanation of why we get partial outcomes every time that we have tension coming from the flap, because now we're changing the molecular expression of the grafted tissue underneath there. And of course, every time that you have tension on the flap, you have to remember that we are not only stretching those vessels and therefore reducing the vascularity that is available on the flap by thinning the lumen of those veins and arteries, but as well by reducing the release of vascular endothelial growth factor that is available within the blood. So again, this is a picture that was taken from one of the classic articles published before 2012. You can see that this author was using only one frozen PRF membrane. You can see this is the picture B taken from the article. And we had a very aggressive flap closure. You can see almost the bluish aspect of a vascular flap that is happening due to the lack of release and the tension that was placed on those blood clots. Okay, understanding again that PRF is not connective tissue, doesn't have the same physical properties of your connective tissue, and will reduce and will resorb if you have too much pressure on compression on those membranes, and will not allow this 2 weeks of release of growth factors. So the concept that we had here, this hypothesis, was to upregulate the PDL cells that we have around those roots by increasing the volume, respecting the concept of biointegrity by modifying our surgical technique. And the aim was to get more root coverage and increase of keratinized tissue. So again, since 2012, 2014, we did have 4 or 5 articles that were published in peer reviews to discuss and this surgical technique. And we have as well couple of book chapters that were published in 2016 and 17 describing in detail the surgical aspect of this FASTP, and I will recommend you to hopefully go on PubMed or purchase one of those books if you want to know more about this technique. So the best way, I think, to summarize it is to show you a clinical case to see how things all came together during these years and the modifications of the classic surgical technique that we had to bring into the table in order to gain good clinical coverage. And the best is to discuss this patient. This patient is suffering from a class 1, class 2 Miller recession. He has root prominence, gingival deformity, and we decided here to perform an FASTP here to in order to improve the amount of root coverage for this patient. And I'm trying to play this video here for you. Wait, sorry. I got kicked out, guys. Perfect. Can you see the video, guys? Hello?
I can see the picture, but not the video.
It's not playing. Oh, sure. Can you help us with the video? Oh, let me go back. Play the video, guys.
Video is not playing.
Okay.
For some reason.
So let me do something else here. Let me go back to the slides. I'm going to take the slide. I'm going to just show you the slides of that presentation. Oh, yeah. No? No? Okay, so what I'm going to do here, I'm going to exit. I'm gonna go to my slideshow. I'm gonna put the slides of the video of the procedure itself. I think that would be better, so we can discuss the detail of this procedure with slides and not the video, because we have some technical error here. Give us a minute.
If you have the video on your computer, you can probably play the video and share the video screen instead of the presentation, and then we can again.
Okay. I don't have it with me.
Okay.
I don't have it with me. So let me go to the. I have the slides. I'm going to put up the slides. I'm going to unhide the slides. It's going to be the best way to do it.
For sure, we will understand the pictures for sure.
Yes, exactly.
Great pictures. Yeah.
Yes, I'm going to do that. I have the pictures. Give me 1 second, slide.
No problem, my friend. Take your time.
Sorry.
No, not for that. Don't worry.
Excellent. Here we go. Perfect. So basically, what we had to do here in order to understand and fulfill the concept. Can you hear me? Can you see me, guys? It's okay? We're good?
Yeah, you're good.
Okay, perfect. So we had to modify, as I told you, the classic surgical techniques that we had in the past in order to fulfill the concept of bite integrity. And one of the major breakthrough that we had into this surgical technique is the utilization of the Vista vertical incision technique that my good friend Dr. Homazadeh, that I taught with at USC, proposed a couple of years ago, and I believe that he's going to be one of your guest speaker in your podinars very soon. So this is an incision that allowed us to make an incision into the tissues, allowing us to have a horizontal preparation. And again, I'm sorry to not be able to show you the video here, but allowed us to have a very, very passive flap relaxation and have the vascularity of the flap maintained because the tip of the papillas were not released, and having very, very minimal incisions done into the tissue, allowing us as well to create pouches in which that we are able to pack the PRF underneath there and suture them into the roots very passively. So what we did as well, not only we had to modify again the incision design, but we had to as well modify the suturing technique. So what we did here is that, as you can see, going to the same steps of our classic mucogenital surgical procedure, perform the root contamination, the root detoxification with EDTA, but as well you can see here we had to place some small composites, flowable composites on the edges of the teeth without curing, without etching, without bonding, and then allowing the composite to lock into place with just the shrinkage that happens to the composite, and use these points as a pulley for the suturing aspect of the tissue. Why? Because we realized that every time that we had sutures going to the straight facial of the surgical site, trying to get a coaptation of the edges of the wound, we would put too much pressure on the flap around those PRF membranes, and we will get a premature resorption of those PRF membranes. So we had again to modify the classic Vista technique suturing aspect and use most of the Marcus Hertzler technique and Otuzur, and combining those two techniques. So again, I just wanted to understand this is not again something different from whatever has been existing. It's just taking bits and parts of different existing technique, taking the best that we believe are suitable for the PRF concept and merging into this FASTP treatment philosophy. So Vista incision, Otuzur suturing technique, and you can see here that through those vertical incisions we're able to pack as much as possible these PRF membranes. Again, the numbers are at least 3 to 5 membranes per pair of teeth. The more the better. understanding again we have an autogenous release of growth factors, meaning that we need to have the maximum amount of PRF membranes available into the site. Placing 1 or 2 membranes again will not do it. You want to place 10, 15, 20 membranes per arch in order to start seeing clinical relevance. Understanding as well for the indication that you need to have some sort of keratinized tissue to begin with to start having this promotional aspect of and the proliferation of the keratinized tissue that you have on site to begin with. Once these membranes have been placed, we did some apical matrix suture that has the advantage of not only maintaining these PRF membranes on the roots, because again, remember, I don't have any interest of having my PRF membranes traveling down into the nose of the patient or on the apex of the roots. The whole concept is to have the PRF membranes as close as possible to the ligaments, to the recessions, so to get the best root coverage possible and induce as much as possible keratinization. So these apical matrix sutures will have the purpose of not only maintaining these PRF membranes close to the root, but as well immobilize the lip movement. Again, concept of biotensegrity, removing as much as possible the pressure and the tension on those membranes and allowing them to express themselves for the next 2 weeks. Once those sutures have been placed, now we're going to advance the flap, as you can see, utilizing our sling suture, interrupted one, using the composite that we place in between the teeth to advance the tissue and get the root coverage away from the marginal tissue. Again, trying to protect as much as possible the PRF membrane. So you can see here, if you look carefully, we have this rectangle, this oval of tissue where the PRF is placed, away from all the irritations coming from flap tension, suturing, and fully allowing this area to heal and promote the tissue. This is again the healing that we get after 3 years. You can see we're able to rebuild this wonderful amount of lost attachment apparatus for this patient, not only from a 2-dimensional aspect, which is the vertical aspect, but as well from a 3D aspect. And again, on the full version of this presentation, hopefully next time I will show you the volumetric changes that we have observed utilizing this technique here by not only increasing the amount of reducing amount of root coverage, but as well improving the volumetric changes around those roots, hopefully by increasing the biotype of these patients and improving the long-term integration of the patient's dentition. This is again the patients you can see at the time of the surgery, and not only the functional benefit of increasing this biotype, but as well aesthetic improvement that this patient is benefiting now that having better aesthetics. We have again the same concept apply on the mandible, following the same concept of biotensegrity, volume, making sure that we have some sort of keratinized tissue to begin with, because again, understanding that this will become a big contraindication. We see we're able to rebuild a proper amount of attachment around those roots and improve the long-term longevity, not only from a dental aspect, but as well from a periodontal aspect of this patient. Again, another challenging mandibular case. Canines that are exposed, a very avascular surfaces, very difficult to graft because of the location, the mentalis muscle that is basically pulling and creating a physical obstacle in terms of, again, concept of biotensegrity, but following the same concept, we're able to deepen the amount of vestibule, gain root coverage, increase the amount of keratinized tissue, and hopefully improve the longevity of these dentitions for this patient and allow them to enjoy the teeth for the longest time away from sensitivity, from discomfort, and of course, improving their aesthetic appearance. This is again one of the most challenging cases that was treated by Dr. Krivitsky, class 3 Miller, very amount of keratinized tissue, and we're again by following the same concept that I talked to you about, respecting again the surgical protocol and using wisely this biological modifier, able to increase the amount of tissue that was formed around those roots by mixing in IPRF, APRF, volume, biotensegrity, suturing technique, Vista incisions, able to create this wonderful new biotype, hopefully with the true regenerations, upregulated periodontal cells, and a true attachment around those roots. So again, people always ask us, where is the data? Again, this is a project that we're working with my friend Carlos. This is again a 3-year 2D analysis of this technique that we are working on and working to publication. 12 patients, 3 years of follow-up, class 2 millers. Patients again had to have 1 millimeter of keratinized tissue. We have 3 years of follow-up. This was again a retrospective studies done by superimposing pictures that will give us exactly, very precisely, better than the utilization of clinical measurements, the amount of root coverage procedure. And we can see by superimposing by the Photoshop technology, the before and after, we're able to see and quantify the amount of volume changes that happen facing those roots. And we see that at 3 years, we're able to maintain a 79% vertical root coverage on those patients treated with the FASTP. Again, understanding that this fulfills and fits into the average clinical outcome utilizing different methods of root coverage with this technology. And we have now a paper that a master thesis from one of the residents that just finished his project, Dr. Naveed here. This is a 1-year follow-up on a prospective studies, 3D analysis of this FASTP technique. We have technology that are available, scanning technology. So we scan the patients before, we scan the patients after. We have treated 25 arches of patients. So these are again multiple sessions, advanced cases, and we're able now to superimpose these volumetric changes and assess not only the 2D but the 3D changes that these patients are benefiting from. And this is again the preliminary data that were found in this article that are not surprising, is that the areas that the patient had most keratinized tissue were the areas that responded the more favorable to this technique, meaning the canines and the maxillary and the maxillary incisors and canine provided us with a better clinical outcome because, again, concept bite integrity, the surgical area is much more favorable. We usually have a band of keratinized tissue that is present, and for these reasons, mixing it with the PRF, we're able to get a better clinical outcome and avoid the utilization of connective tissue graft versus the mandibular and incisor teeth, where we have the least amount of keratinized tissue, where the surgical site is much more hostile, much more difficult to work with, and the gains were much more modest on that area. So again, this is a question that is always asked to me: when do we add, when do we don't add? So this is again going back to the concept of periodontology and the studies done by Professor Baldi. Every time that a flap has or tissue has less than 1 millimeter of keratinized tissue, we would like to add connective tissue, because we know at this point that utilization of fibrin by itself is not enough, because we need to have a base of it. Most of the time, as you can see on this picture on the left-hand side, we like to combine these technologies together to get the best clinical outcome. And every time that we have more than 1 millimeter of keratinized tissue, this is the time that we prefer to not go to the surgical site and harvest the connective tissue, and we have more tendency to lean towards the utilization of PRF alone, and in order to get adequate or similar amount of wound healing and patient satisfaction. So again, I think I'm getting to the end of my time that was allocated. Respect the body and its limitation, understand the sound biological concept that comes with it, and you need to be able, of course, to be very versed and understand all the different surgical techniques, the different limitations and different applications of the technology that is available, and merge it with the biological concept that we have, and at that point you'll have a winning formula to provide your patients with the best clinical outcome. So this is the end of my presentation.
Thank you so much for your
Thank you.
amazing presentation, my friend. Thank you so much. We don't have questions from our audience, but
okay.
I love it when you compared the PRF and the CTG, the connective tissue graft harvesting, and you wrote and you spoke about it. The question that you can't compare one to the other, because that's true. We can't compare the connective tissue graft with the PRF. That's totally different. And then I like it because sometimes I can hear some people trying to say, no, you can substitute the connect tissue graft for the PRF, and then that's a huge mistake because we already have some systematic reviews about it, and we know that we can't do it. And then that's good. That's amazing to hear from you.
Yes,
And
this was, I think, one of the biggest misconception that we had is because dentists they like to feel, they like to see, and the PRF membranes has a very good, very familiar, very fulfilling texture, like the connective tissue. And I think a lot of us fall into the trap of thinking that we had a replacement for it, not understanding the concept of the wound healing mechanism that are completely different. And I think PRF is a biological modifier. Remember, it's there only for 2 weeks. And I think it has to be compared with the other biological modifiers that we have in the market, like PDGF or Emdogain, for instance, and see if you use them, you know, in a control group, if we can get the same amount of root coverage or not, compared to those technologies, and not against a connective tissue graft that works in a completely different pathway of healing.
perfect. Another question is how long how long do you after place the EDTA in the root? How long do you leave it there?
So we leave it 2.5 minutes, and then we'll wash it, and we apply again 2.5 minutes. So again, these are empirical techniques that we have 2 times. Again, these are the studies done by Jan Ingelberg from the University of Loma Linda, and these are again the recommendations by that group published in the 90s. So this is again the same protocol that we would use in guided tissue regeneration, because that's all we have.
Perfect.
Yes.
Perfect.
Yes.
And I love it. The question about the Photoshop, the comparison of the before and after. I think that's a good method to evaluate the recovery, the soft tissue recovery. I think that's a good method to do it using the Photoshop, and then you can have the percentage of the soft tissue recovery. And but more than that, I think that the other method to evaluate the volumetric change, I want to see that. You need to show me that. I want to see.
Yes.
Maybe you. I'm waiting
I have
for.
the thesis. Yes, the thesis by Dr. Navid has just been finished, like maybe a few weeks ago. So I have the copy of that thesis that I was helping him with because I was part of the committee. I will email you the PDF and the word of this methodology, so you can look into that.
Because this method is
Yes.
pretty nice. Pretty nice. I saw you can see not only what you do, did you have before, but you can see the after, and you can see the volumetric change. That's amazing.
Exactly. That's
3D,
good. Yes, this is
totally 3D.
yeah. This is a yeah. We didn't have this technology available before, but now we have a scanner, so this is much more easy to do that in this exactly. And some exactly.
And then another thing is the question about the Vista technique. I love the Vista technique from Dr. Hadzadeh. I think that
Yes.
you can provide more vascularization for your surgical site, and then I think that's pretty good. The question about the open wound concept, or especially when you work with dental implants, I think, and then when you don't have keratins, that tissue, sometimes we need to go to more. We need to go more palatal, and sometimes or lingual. It depends if you are in mandible or maxilla, and we need to bring this tissue, and then sometimes we can leave the bone. We can leave the bone. the exposure. We can expose the bone,
Mhm.
and then, we can use the PRF to mimetize the tissue, the soft tissue in that area. And then when we do that, we will have the something like a mesh of a new tissue formation, and then you have the keratins, that tissue, for our dental implants. And then I think that's great. What do you think about it?
Yeah, this is definitely so. That's for implantology, obviously, that you're
Yeah.
referring to. And yeah, I think I have a good friend of mine, Dr. Professor Carlos Dantas, who is from Brazil as well. He talks about that, and he has published, and he's giving a lot of courses about that. So yes, the open wound technique is a very good biological sound concept. Um, Personally, I'm more of a closed wound person because there is a lot of variations based on my experience that can happen. Not that this concept is not sound and solid; it works very well, but especially in the aesthetic area, you have to be very careful because then you have no control over the tissue height. But definitely, the amount of keratinized tissue that you're able to generate is substantial by this secondary healing that is supercharged by the PRF, basically.
I see.
Yes.
Yeah, but, obviously, when you have something like just one or two teeth to restore, I think that you're right. But when we have multiple dental implants, or for full rehabilitation, I think
Mm-hmm.
that's pretty good, because
Yes.
uh, we already have some articles about the question. Oh, you don't need the keratins, that tissue around the implant for full rehabilitation, but I think that's I don't like it. I prefer the keratins, that tissue
Of
around
course.
my abutment, or around my dental implant. I think that will be the best for the survivor of my implant. Did you agree with
Yes.
that?
Oh, 100%. And this is the new trend today. We know the concept, the tissue is the issue and the bone sets the tone has changed today. We know that in order to maintain crestal bone, regardless of its thickness to begin with, you must have keratinized tissue around the neck of your implant. So we have studies done by Thomas Dickenvicius and his colleagues, and a battalion of articles that were published afterwards. The fact that if you don't have keratinized tissue, with time you will start having crestal bone remodeling that is accelerated and definitely much more sharper compared to patients that have a nice band of keratinized tissue. So today patients are living longer and longer, meaning that we see our patients coming in our office. We are younger and younger, as well as practitioners providing this kind of procedures, meaning that it's very common for us, I think, to see our patients after 20, 30 years, hopefully 40 years of practice later. We'll see what happens. But the amount of keratinized tissue is going to be like a seatbelt, protecting the neck of those implants against the test of time and maintaining the integrity of your implant and the restorations for your referrals. So I think it's just you cannot get away without it today. So this is totally part of the protocol of what we do. We don't use PRF for dental implants and soft tissue. So again, I know this was not the topic of the discussion today because we have failed. I have not found yet the formula how to increase keratinized tissue around titanium, because again we don't have ligament, we don't have PDL cells. So still, if I need keratinized tissue around implant, I will use a free gingival graft, or I will use a subepithelial connective tissue graft coming from the patient. But this is part of I would say 8 out of 10 of my patients, when we do surgery today, we are doing some sort of soft tissue manipulation to increase the zone of keratinized tissue, now by incision design, by additive, whatever we need to do to make sure that the patient leaves with more keratinized tissue than when they came in. Definitely.
Yeah, sure. And then we know that because we already have systematic review about it, when you combine the soft tissue graft, the connect tissue graft plus PRF, we will have the better results than without
100%.
without only keratin that tissue. And then
Exactly.
I think that we are working with the best for our patients. And then I think that's the mean the mean of our field. I think that's what we need to
Yes.
for our patients.
You know, one of the wonderful indications of PRF in mucogingival surgery, especially if you need to harvest, is the palate. So even if you need to take connective tissue graft or gingival graft, take a couple of membranes, place them onto the donor site. You know, you will get much faster healing, much better patient's experience. You know, there's studies actually, control studies, prospective studies that are showing that every time that you add PRF into the palate, you're actually reducing the healing time and improving the patient's experience. So these are factors that I think are needed to be considered, even if you don't want to use it as your substance of donor, but you can use it into the recipient bed to improve the quality of the healing of the patient.
I totally agree with you. I think that's the best option for sure. I totally agree. If you have some defect in the palate, you can use the PRF to cover that area. Not only
Exactly.
for connect tissue graft, but if you have something to do in the palatal area, if you need to remove something there, some pathology, some tumors, or anyways, if you need to remove something in the palatal area, we need to cover with PRF. That's the best option for our patient.
Yes.
Better than the periodontal cement. Cement for.
Yes. We don't use those anymore. Since we use PRF, we don't use those co-pack and dressing, periodontal dressing. We don't use them. Exactly.
Periodontal dressing. Yeah.
Yes. No stent anymore. Exactly. We place the PRF, couple of sutures, and then let it heal. That's it.
Yeah.
Let PRF do its magic.
For sure. Yeah. So
exactly.
I'd like to say thank you so much for your presentation. Amazing presentation.
My pleasure.
Much to be today with us, and I hope to see you soon. You and your beautiful family. I hope to see you.
Thank you, Carlos.
Thank you so much. I think that everybody liked your presentation. Because it was amazing presentation. And
thank you.
Keep safe, and let's talk later, because we have a lot to talk about our study.
Absolutely. Thank you so much. Thank you for the opportunity. Thank you again for the group to invite me. Thank you so much for Carlos taking the time on this Sunday to do this moderation, and thank you for the audience to wake up on the Sunday to listen to a PRF lecture. So I do appreciate you, and don't hesitate to contact me to Facebook or to my email if you have any questions that I can answer following this presentation. Thank you.
Thank you, everyone. Goodbye.
Thank you. Bye.